Good afternoon, everyone, and welcome to the next webinar in our Staying Connected series, which will cover counselling considerations and expanded cfDNA-based prenatal testing. I'm Kelly Lochenberg, the Genetic Counsellor at Next Genetics. I hope you're all keeping safe and sane in these unprecedented times. So as you are aware, non-invasive prenatal testing is one of the main services provided by Next Genetics, and we were very excited to be able to bring genome-wide NIPT in-house a few months ago. PriceScreen Plus is able to provide information about aneuploidies involving chromosomes 1 to 22, sex chromosomes, and deletions and duplications larger than 7 megabases. PriceScreen Plus utilizes Illumina's VerySeq technology. As a genetic counsellor, I'm very excited to have Christin Coffeen, a fellow genetic counsellor, with us this afternoon to discuss counselling considerations and resources specifically for expanded cfDNA-based prenatal testing. Christin is a licensed certified genetic counsellor with more than 18 years of experience. She's currently on the medical affairs team at Illumina with a focus on clinical implementation and healthcare provider education of NIPT across the United States, Europe, Middle East, and Africa. You may recall Christin joined us for our NIPT symposium last year, and the insight and practical resources she shared with us has been very valuable. So before I hand over to Christin, just a reminder that if you have any questions during the presentation, please type them into the question box and we'll answer them at the end. So thank you so much, Christin. We look forward to hearing your presentation.
Thank you, Kelly. I really appreciate it. And it's a pleasure to be here with you all today. As Kelly mentioned, what I'm going to be focusing on as an extension of what my colleague Lieve spoke about a couple weeks ago is looking at expanded cell-free DNA-based prenatal testing, specifically the counseling considerations and resources. This is my disclaimer slide. I am an employee of Illumina. And here's just a general overview of what we're going to touch on this evening for you all, morning my time. I'm going to give just a general background of cell-free DNA-based prenatal testing. Just as a reminder, I know this is focusing on expanded cell-free DNA testing, but just reminding us about that general background piece that we need, including where we started with NIPT, the premise of what we're testing, the society guidelines that are out there, and really why we are now looking at screening beyond the common aneuploidies, so beyond the common chromosome conditions that we initially started with NIPT, and then going into and focusing on the counseling considerations with a case example there for you all for consideration, and then also going over some counseling resources and tools that are available to you all, not only for your own general education, but to help you in your conversations with your patients. And as I mentioned, we'll be starting with a background on just prenatal screening and testing in general as it pertains to NIPT. And what you see here is a prenatal prevalence of chromosome abnormalities specifically at birth, and the common ones that we think about. So starting on the left-hand side here with Down syndrome, followed by trisomy 18, 13, 45X, which is also known as monosomy X, and sex chromosome abnormalities, the common ones being triple X, Klinefelter syndrome, and XYY. And then over here you have the bucket of more rare conditions, which are things like chromosome abnormalities involving other chromosomes, extra missing whole copies, structural changes, so forth and so on. And typically what we hear a lot about are these conditions over here on the left-hand side, because as you can see, they are quite common, and they're what we've traditionally been screening for non-invasively throughout the availability of prenatal screening and testing options. And as we look at this slide here, I like to remind people of the current paradigm and landscape of prenatal screening and testing and what we have available to us, keeping in mind that previous slide that I just showed. And what you see here is at various points during a pregnancy journey, there are various options that are available to pregnant women to screen or test for chromosome abnormalities. Again, what we're focusing on here for this presentation. And what you see here is you see chorionic villus sampling, also known as CVS, amniocentesis. This is what we would call your diagnostic testing options. So they are looking at the entire chromosome picture, what we've traditionally known as karyotype, so a picture of the chromosomes, counting extra missing whole copies of all of them, and then able to see certain structural changes down to a certain resolution. The nice thing about those options is it is giving you more information in a more diagnostic fashion, but there is a risk associated with those procedures. And one of those risks is the risk of miscarriage. If you look up here at these first trimester screen and second trimester screen, these are options that we started initially with second trimester screening decades ago, and in the course of the past 20 or so years transitioned into having the availability of first trimester screening, which is called the first trimester combined test in some parts of the world. And what they are is they're nice options because they're non-invasive. There's no risks associated with them. There is no risk of miscarriage. But to the flip side of that, the difference is the type of information that you're going to get. You're not going to be looking at all the chromosomes. And what you're getting is not a yes or a no, like you get with a CVS or an amniocentesis. It's a risk assessment. It's saying, what are the chances for a pregnancy to be affected? And traditionally, the detection rates for both the first trimester combined test and second trimester screening are quite variable. And they routinely are geared toward a false positive rate of about 5%, meaning something comes back as an increased risk, but the pregnancy is actually okay. And it's limited in what it's looking at. They screen for Down syndrome and sometimes trisomy 18 and trisomy 13. And they're limited in the times in which they can be offered during pregnancy. NIPT, which is available, can be offered as early as 10 weeks all the way up into the third trimester of the pregnancy. And what it started with was screening for those common aneuploidies that I showed you in the previous slides. So trisomy 21, trisomy 18, trisomy 13, and then in some instances extending into the sex chromosome abnormalities. And what it really is like the first trimester combined test and second trimester screening, it is non-invasive, so there is no risk associated with it. But when we think about offering another non-invasive test into this paradigm of testing, what do we want it to be able to do? Obviously, it's nice that it is non-invasive, but we want it to be able to perform better than those characteristics that I was telling you about the first trimester combined test and second trimester screening. So you want the detection rates to be higher. You also want less false positives. You also want to, by thereby reducing the false positive rate, you're reducing the risk of fetuses exposed unnecessarily to a risk of miscarriage from an invasive procedure, and you want a test that can be easily offered. And also thinking about not only the test performance characteristics, so low false positive rates and high detection rates, but I also like to remind people of what we're actually testing in the realm of NIPT. And I always say when I'm presenting on these things that this is one of the most important slides to keep in mind, the source of what is being tested, what we're looking at. And we are looking at cell-free DNA in a pregnant woman's bloodstream. I like to remind people that we all have cell-free DNA, whether or not we're pregnant. When a woman is pregnant, she not only has her own cell-free DNA, but she also has cell-free DNA from the pregnancy itself. Specifically, it is coming from the placenta. And the part of the placenta that it comes from is the cytotrophoblastic cells of the placenta. So if you're thinking about NIPT, it's a nice analogy for it is very much similar to like a blood test version of a CVS. Since a CVS is a biopsy of the placenta, that diagnostic procedure I just spoke about, and NIPT, because it's looking at the cell-free DNA from the placenta, they're very similar to each other in how we have to think about them. And that'll become important when we're talking about the counseling considerations for NIPT in general, including expanded NIPT. The other things to keep in mind about it is because it is a combination of maternal and placental cell-free DNA, we are performing this testing under the assumption that the pregnant woman herself is not affected with a chromosome abnormality. And most of the times that is true, but it has to be kept in mind. And also, because it is representative of the placenta, sometimes there can be conditions where the abnormality itself is isolated to the placenta and the pregnancy is just fine. And again, that's something we have experienced with CVS over the years and learned from, and that becomes important in those counseling considerations. The nice thing about cell-free DNA is it's detectable early in a pregnancy, which is why NIPT can be offered reliably as early as 10 weeks, and it is virtually undetectable within hours after delivery. So the cell-free DNA from that pregnancy is cleared from the pregnant woman's circulation. So NIPT is a test that can be reliably offered from one pregnancy to the next. And as I mentioned when I was talking about some of the benefits of NIPT and the goals of NIPT here is really those higher detection rates and lower false positive rates when compared to the traditional serum screening that we've had for years. And this slide here is a summary for you. It's a meta-analysis that is very technology independent, and it's looking at all the publications out there on NIPT for the common aneuploidies. So over here, it lists those aneuploidies for you on the left-hand side. You'd see their detection rates here, which are quite high when you compare those to serum screening, and the low false positive rates. And what I also like to point out here is just with regards to the ability to perform expanded NIPT, it really is because of those benefits of a whole genome sequencing type of platform that you have with TriScreen Plus that enables us to give us the ability to do this more easily. And you see here, when you look at whole genome sequencing platforms, for the common aneuploidies, you do see slightly higher detection rates and lower false positive rates. So again, keeping in mind with that paradigm of NIPT, of those higher detection rates and those lower false positive rates, that becomes important again when we're talking about counseling considerations. And with society guidelines, there are a lot of guidelines out there. I just wanted to focus on the pieces that would be relevant and important when you're thinking about talking about things with your patients. What I always like to bring up is when NIPT first launched at the end of 2011 in the United States, the ISPD, or the International Society of Prenatal Diagnosis, responded within a couple weeks with a preliminary practice guideline statement. And as Kelly mentioned, I've been in the prenatal genetic counseling field for a very long time, and I have never seen professional medical societies respond so quickly to a new technology. Within weeks and months following ISPD statements, several societies around the globe also came out with guidelines and practices for the consideration of NIPT. And since that time, and since some of their initial statements that have come out, many of those statements have been revised several times. And some of the common things that they speak about is, who can NIPT consider being offered to? And we see this varying around the world. There are many factors that go into this. There is health costs, how healthcare may work in various countries. NIPT can be reliably offered to women considered at high risk for aneuploidy due to the conditions that you see here, and for patients at low risk for aneuploidy. A lot of those early position statements that came out talking about and focusing on high risk was because the initial studies related to NIPT were focused on those high risk populations, because those were the populations that had more cases of these aneuploidies. So if you're validating a new technology, you want to have a lot of those abnormal cases to be able to look at. And that's why, because a lot of those initial studies came out looking at these traditional high risk populations. Since that time, studies have come out showing that it can also be reliably offered to patients who are at low risk, and that the detection rates and false positive rates are statistically significantly better than traditional screening through the first trimester combined test and second trimester screening. Again, but how this is decided to be offered varies around the globe based on various considerations. The other thing I wanted to point out as we're going to be considering counseling considerations is thinking back to what I spoke about the source of what we're actually testing and looking at, that cell-free DNA. And because of that, while the detection rates and false positive rates are very good with NIPT, like any screening test, and because of the source of what we're testing, there are limitations. There is the potential for false positive and false negative results. And because of that, the societies like to remind us that with any increased risk result on an NIPT, that needs to be followed up and confirmed with an invasive diagnostic procedure. And what that procedure may look like and the testing that may be performed on that is going to be dependent upon what abnormality you came back at high risk for on the NIPT. So as we just spoke about, we talked about the source of what we're looking at with cell-free DNA, which is important to keep in mind when we're thinking about not only its test performance, but the limitations and the things to keep in mind when talking to patients. It traditionally and historically started by looking at the common aneuploidies, because that is what we were used to screening for, and that's what we had more information for. And if you think about it, because it is cell-free DNA and it's not just specific to one particular chromosome, there is that ability to look for more. So why should we? And that's what I'm going to focus on in this section here. And I'm going to revisit this slide that I showed in the beginning, where initially I was talking about these common aneuploidies that you see here on the left-hand side. But focusing on this rare group here, this 17% bucket that we have, which when you look at it in comparison to trisomy 18 and trisomy 13 and the sex chromosome aneuploidies, they're not uncommon collectively. And by not looking at them, even though we have the ability to do so, you would be missing out on a large percentage of abnormalities that can impact pregnancy. And again, in that group, what we're thinking about are extra or missing copies of whole chromosomes other than the ones that are listed here, and then any structural changes, other type of marker chromosomes, so forth and so on. So what standard NIPT came out with and what can be seen is, you can see here, this is a table here for you showing screen positive rates. You have trisomy 21, trisomy 18, trisomy 13 in the blue area, and corresponded over here on the right-hand side, you see those corresponding chromosomes circled in blue for you. In green, you have your sex chromosome abnormalities, which are circled here on the right-hand side. And what it's showing for you in this second row is the screen positive rates for them for trisomy 21, 18, and 13 individually, and then collectively for the common sex chromosome aneuploidies, including these conditions that are listed here. If, as I mentioned, these are the screen positive rates of what we can see with traditional NIPT. What if we were able to look at more? And if you add on to this, what we saw on the previous slide, you see this purple area here, which is looking at the abilities of a genome-wide screen, looking at rare autosomal aneuploidies. And this is all highlighted in purple here on the right-hand side, where you see looking at a whole karyotype, and genome-wide partial deletions and duplications down to 7 megabases. And 7 megabases is important because that is the resolution of a traditional karyotype. So what we're really talking about here is the ability to use the technology of NIPT to screen beyond those common aneuploidies and really giving you to the best resolution possible, screening for what we would diagnose on invasive diagnostic testing. So CVS and amniocentesis, giving you that similar type of picture down to the same resolution. Again, it is screening, but being able to do that. And if you look at the screen positive rates for these things, as I showed on that first slide, is, the percentage of these is not inconsequential, but when you compare the screen positive rate collectively to what can be seen with rare autosomal aneuploidies and partial deletions and duplications down to 7 megabases, you will see that the total screen positive rate is greater than that of what we see with sex chromosome aneuploidies and approaches that of what we see collectively with Down syndrome, trisomy 18, and trisomy 13. And if you look at it on an individual level, the collective screen positive rate on a genome-wide screen that you see is greater than trisomy 13, trisomy 18, which we have been screening for, and even in some cases Down syndrome. So that's from a screen positive rate perspective, showing that they're not inconsequential. From a clinical perspective that you can see here, again, things that we screen pregnancies for and traditionally test pregnancies for, are there risks for early miscarriage, growth restriction, other pregnancy-related complications, fetal anomalies, other things, other types of birth defects. These rare autosomal aneuploidies and these deletions and duplications down to 7 megabases do have clinical association similar to what we see in things that we've already been screening for. And I know that my colleague Lieve touched on this in her previous presentation. And if we think about it not only from a screen positive rate perspective, but also looking at studies that have been published regarding genome-wide NIPT. And there are certain groups around the world that are leading the charge and are the early adopters and those key opinion leaders in this area of genome-wide NIPT. And one of those groups is the Trident group, which is from the Netherlands. And they have been looking at this for several years. They have had 2 separate phases to their research, one which is cited here, which is the first version of the Trident study, which was offering NIPT to patients considered at high risk for chromosome abnormalities. They have since subsequently started to conduct a second phase to their study when they offer NIPT to all women regardless of risk. But as part of that first study, what they were looking at is not only 21, 18, and 13, but they also wanted to report on when they were able to see chromosome conditions beyond the common trisomies. And what did they see there? Was there clinical relevance? and to begin to try to peel back the layers of clinical utility. And what they did see was, as you can see here from these quotes, is that genome-wide NIPS or NIPT, while it did lead to a slightly increased risk of invasive procedures by just 1%, what they saw was an increased prenatal detection of true fetal chromosome aberrations that would have potentially gone undetected had they not done the expanded NIPT. And even more importantly, that more than half of these cases where an aberration was found in something other than a common aneuploidy, that 20-week anatomy scan in more than half of those pregnancies was normal, and it was reassuring to them. So again, if we're relying on that 20-week anatomy scan to tell us if we should screen for more, and because we see abnormalities, we would have missed the potential to diagnose these fetuses with these conditions because they looked falsely reassuring on ultrasound. And from that, they concluded that the findings other than common trisomies are clinically relevant for pregnancy management, and that there is potential for clinical utility in performing genome-wide NIPT, so beyond the common aneuploidies. Apologize, my slide, there we go. In addition, if you think about looking at not only the screen positive rates and the information that we've seen both from the Trident groups and other groups around the globe, when we think about the impact of chromosome abnormalities in general, whether it is the common aneuploidies or whether it is more of the rare autosomal aneuploidies, there is commonalities among them. Any imbalance in chromosome information causes an increased risk for pregnancy loss, whether it is miscarriage, demise, or a stillbirth, congenital anomalies, which may be seen on an ultrasound or may not be seen on an ultrasound, intellectual disability, developmental delay, in some cases reduced life expectancy, adverse pregnancy outcome, which can include growth restriction, preterm delivery, low birth weight. So not only things that impact the structure of the pregnancy, but also things that can impact pregnancy management in and of itself. And again, these are not things and effects that are just limited to the common trisomies, but really apply to all chromosomal information across the genome, which is why we've been looking at these things via CVS and amnio for these years and offering this to patients. The prognosis in and of itself obviously is influenced by, the amount of information that is gained or lost, the presence or absence of mosaicism, the chromosome that is involved. And again, but just keeping it high level when talking and discussing with patients, that high level review of looking at this information is important for assessing the risk to the pregnancy for those things that are listed above. And obviously prognosis is going to be impacted by the chromosome involved in the amount of information. And there are resources out there that can guide you through that, including Next Genetics in and of itself. And you heard an introduction today from Kelly, that amazing resource they have with their genetic counselors on staff. So in the previous slides, I showed, the screen positive rates and the clinical implications of screening beyond the common aneuploidies. The other thing to think about is, what do women want? And we're starting to see this data more and more. And this is information that came from the second part, Trident 2 study, where they again are looking at offering NIPT as a first-tier screen, and not only offering it, but they also reported on what they saw. And so as part of Trident 2, what is offered to patients is you can either do the screening for just 21, 18, or 13. However, on patient request, they are offered the ability, patients are offered who were enrolled the option to go beyond 21, 18, or 13 and screen for more conditions across the genome. And what they saw was 78% of those women who were offered this chose to have these reported. So we're seeing that pregnant women do want this, and this is based on published information that's listed below for you. Anecdotally, we're seeing similar information come out of other groups that are offering genome-wide NIPT, such as other groups in Europe, such as in Belgium, where they also offer expanded NIPT, where you hear in presentations from their key opinion leaders that, again, the more women than not are requesting, when they're offered it, expanded NIPT, understanding that it has the ability to look for more. Again, the nuances into what is influencing women to choose expanded NIPT over the basic panel of information that those studies are forthcoming. I'm sorry, I don't know why my screen just did that. That information is more forthcoming in other surveys and studies that are being conducted as part of this. So if you think about the screen positive rates and the clinical impact of these conditions, and also what women are wanting and the offerings that are now available, how do you begin to talk to your patients about this information? And that's what we're going to focus this next section on. And what I like to remind people is that genome-wide testing is not new. We've been doing it with amniocentesis, where you look at all the chromosomes. The resolution of karyotypes obviously has improved over the years, where we just were able to, in the beginning phases, decades ago, just look at counts of chromosomes, but now we're better able to decipher chromosome imbalances related to deletions and duplications down to a certain megabase level. The advent of CVS in the 1980s, where we were basically essentially a placental biopsy. The advent of microarray testing in the past decade on CVS and amniocentesis samples. And again, so looking at things beyond 21, 18, and 13 is not something new. We have been doing that for years. And variants of unknown significance or results of unknown significance also is not something new to us. We've seen it with microarray, even before microarray with karyotypes on amnio and CVS. Many of you may be familiar with, every once in a while we'd get a result and we didn't know what it meant. You could see a marker chromosome where it was just extra chromosome material, but we didn't know where it was coming from. We didn't know what type of information was on there, how it would impact a pregnancy. So again, parlaying those lessons that we've learned from our experience with amnio and CVS and microarray and the uncertainty that we've had with those things can be directly applied to when you're talking to your patients about expanded NIPT options. Pre-test counseling considerations, one of the first steps is ultimately you as a healthcare provider determining if NIPT is even an appropriate option for your patient to be considering. And as a genetic counselor, one of the tenets that is near and dear to my heart is the ability to be able to provide patients with as much information as possible for them to make a true informed choice so that they understand what's being presented to them and they can make a decision based on that information which aligns with their values and what is important to them, and doing it in a non-directive manner. And that is one of the tenets of genetic counseling, providing patients with this information and having them make an informed choice that is up to them. And things that are important in that, pre-test counseling conversation to help you to decide if NIPT is even important for your patient is, looking at the maternal medical history, the pregnancy history. Has there already been an ultrasound performed where we see soft markers or abnormalities that make us concerned, where we may want the patient to consider more of a diagnostic procedure, but what if it's one of those patients who truly, no matter what, doesn't want to have an invasive diagnostic procedure, but wants to have as much information as possible? Family history. Is there family history there that is significant for something other than what NIPT can screen for? Are there any carrier test results? Are both parents in a pregnancy carriers for recessive conditions like sickle cell anemia or cystic fibrosis? Those are things that NIPT would not be looking at. So those are patients that would want to consider another way of testing for those things. So really taking all this into consideration, that picture of the patient at that point in time with the information that you have, and determining if NIPT is appropriate for that patient. And then if it is, having that conversation with the patient about, this is what we're able to look for. These are the risks, benefits, limitations of your options. There are screening options versus diagnostic test considerations. So thinking about the information that can be gained from a diagnostic procedure and balancing that with those risks versus something non-invasive like NIPT and what it is able to look for. If and always in those conversations reviewing, again, not the nitty-gritty necessarily of the test performance statistics and diving into the exact statistic for each condition that's being looked at, because we don't do that with amnio or CVS. We don't go through the exact statistics that there is for looking at diagnosing Down syndrome or trisomy 18 or trisomy 13 or trisomy 16 or monosomy X. So when thinking about it from an NIPT perspective, it would be similar, just looking at it as a whole. And basically what's important to remind patients is that while NIPT is a great test, it is a screening test. So there is that possibility, as we discussed previously in the earlier parts of this presentation, for false positive and false negative results. And there are reasons for that. And if a positive test result is found, a high risk result, a diagnostic testing confirmation is going to be suggested. And based on what's seen on that NIPT, there may be extra testing on that CVS or amnio that may need to be done, and that can be determined based on the NIPT result. So just advising them that we're looking at all the chromosomes. It is information that helps you, again, with those slides that I showed previously, in assessing risks for birth defects and intellectual disability and pregnancy complications and so forth and so on. And that the conversation, if something comes back as an increased risk, would obviously be more tailored depending upon what comes back on that. And then in addition to diagnostic testing confirmation, any other management considerations that you would be discussed at the time following their NIPT if something were found. So just reviewing those differences between diagnostic and screening, false positive and false negative results can happen with NIPT, and if something were found, we would need to confirm with an invasive procedure, and there may be other tests that need to be considered after that. After a normal result, I always like to remind people that to have that conversation with the patient, that's great that your NIPT came back screen negative, but reminding them that the risk assessment is limited to the condition-specific fetal conditions. So looking at those chromosome abnormalities with a resolution down to 7 megabases, that nothing is 100% specific or sensitive. And so there is that risk for false positive and false negative results. And again, always using NIPT as one test that is being offered to a pregnant woman during the duration of her pregnancy, and those test results should always be used in the context of all available clinical findings. So if your initial assessment for offering somebody NIPT, if that has changed during the pregnancy because something new has come up, just because they've had NIPT and you may be concerned about other things, it doesn't eliminate offering them additional testing later if needed and warranted. After an abnormal result, again, these are conversations that you would go into more detail about when setting the stage in the beginning in your pre-test counseling with anticipatory guidance of, this is why we're looking for these things. Each type of abnormality that we see is going to have its own follow-up path and care pathway, and letting them know that you would just, go over these things in a lot more detail if something is found. You don't need to put that burden on the pre-test counseling. But in the post-test counseling piece, after an abnormal result, really driving home, like we spoke about in the beginning when we were talking about the source of what we're testing, and reminding you of those society guidelines that results confirmation needs to be offered, either by a CVS or an amniocentesis, depending upon where a woman is in her pregnancy. And depending upon what was seen on the NIPT, additional testing on that CVS and then amniocentesis may be indicated. As my colleague Lieve went over in her previous presentation, uniparental disomy studies may be appropriate if, depending upon which chromosome came back as an increased risk on the NIPT, possibly microarray testing, maybe a FISH probe for a specific region of a chromosome. And those are things that your resources at the lab can help you with, to have that conversation of what may be the appropriate follow-up testing for this patient, given what was tested as a screen positive. And for patients who may not want to go any further, they're fine with the information that they have. It's not going to change anything about the pregnancy for them, and they just don't want to do anything else prenatally, keeping in mind that at birth, postnatal testing would absolutely be indicated if nothing was done prenatally to confirm what was going on. And also, if there's anything, if a patient happens to say, yes, I do want confirmatory testing, there may be things that come up as a part of that where postnatal testing still may be indicated, again, depending upon what was found. In addition to results confirmation, there are, again, depending upon what came back screen positive on an NIPT and what that results confirmation is showing, there are other counseling and management considerations that would depend upon that. For example, follow-up ultrasounds, not only just looking at the anatomy, but the growth. because of the risks that may exist for pregnancy complications such as growth restriction, preterm delivery, low birth weight, monitoring those things during the pregnancy. And then other management types of considerations and possible testing may depend upon where this pregnant woman is during her pregnancy and any other history that may be there contributing to your interpretation of that NIPT result. And I know that's a lot of information to consider when you're talking about post-test counseling, but again, reminding you of the fact that it's not something new. And this is a great quote that I love here from one of the first publications from the first half of the Trident study, where they talk about post-test counseling for NIPT. Yes, it can be considered challenging, but due to the origin of the cell-free DNA. So thinking back to what I talked to about the source of what we're testing, the NIPT result, in fact, resembles the cytogenetics result of a direct or short-term culture CVS of your chorionic villi. So keeping in mind that very much that NIPT result that we're getting, the lessons learned from CVS will help you in those conversations and post-test counseling with patients for an abnormal NIPT result, whether it's for 21, 18, or 13, or more rare autosomal aneuploidies or partial deletions and duplications. So the clinical significance of an abnormal NIPT result and the most appropriate diagnostic test, you as the healthcare provider can use data from a large number of studies on cytogenetic analysis and our experiences with CVS. And a very influential KOL that I do like to point people to is the last author is Grati, G-R-A-T-I, who is a cytogeneticist based out of Italy and has done a lot of work with CVS and has some great publications out there about how to talk to patients about a positive NIPT result based on the lessons learned from CVS. And for the sake of time, there is one case that I just wanted to highlight to you about the benefits of expanded NIPT in this situation and something that would have been missed if this woman was not offered the option of expanded NIPT. And this is a 36-year-old woman where NIPT was performed at 11 weeks because of her age. It came back with an increased risk for trisomy 15. A follow-up ultrasound at 12 weeks showed a viable fetus with no structural abnormalities. Based on the increased, so she felt comfortable waiting, not doing a CVS and waiting for an amniocentesis and a SNP array. So an array was performed on the amniocentesis. That was normal. Because chromosome 15 is one of those chromosomes that is impacted by the effects of uniparental disomy or UPD, on the amniocentesis, even though it was normal, the healthcare provider also had performed maternal UPD testing or UPD analysis for chromosome 15 because of the associated risk for certain imprinting disorders, one of which is Prader-Willi syndrome. And this test result, that follow-up extra testing on that amniocentesis did come back positive for Prader-Willi. And what I like to point out is this healthcare provider would not have even known to do testing for Prader-Willi if it had not been for that NIPT result. Fetuses with Prader-Willi syndrome typically look normal on an ultrasound. It's usually after birth where you notice the impact of a severely hypotonic infant. And then over time, Prader-Willi syndrome is associated with developmental delay, intellectual disability, the inability to know when you're satiated. So many of these children eat uncontrollably and develop complications related to obesity. And so this is something where NIPT was able to guide that management, that pregnancy management and that testing management that would have been missed, and a woman would not have known this information before a baby was born. A subsequent placental biopsy after delivery of the pregnancy did note that there was mosaicism for trisomy 15 in the placenta in and of itself. But again, this is a situation where it looks like this was confined to the placental, that trisomy situation, and that things in the amniocentesis, you did not see trisomy 15, but because of the impacts of confined placental mosaicism and something called trisomic rescue, you can still have that ability for a syndrome associated with that. And again, these are conversations that the resources at NextBio can help you with, based on what is positive on your NIPT result, what testing should be considered, and if there's any extra testing that should be considered on that amnio. And in the last few minutes, I just want to go over some resources and tools that are available there for you. As a genetic counselor, these are things that are near and dear to my heart. Having tools that promote informed decision-making and informed choice, and giving women the time that they need to really make decisions that are consistent with their values regarding their prenatal screening and testing options. And this is a slide here just depicting a sampling of tools that are available. Up here in the top left corner, you see a patient counseling guide. Counselors often refer to them as flipbooks. It's a visual aid guide that's meant to help healthcare providers in their conversations with patients. And also a picture here of a pre-test counseling app that is publicly available, which I'll go over with you in the subsequent slides. These images here are pictures from the flipbook that exists. It not only has information on basic NIPT for 21, 18, and 13, but also information when considering expanded testing. So rare autosomal trisomies, potential clinical outcomes, those impacts associated with mosaicism that my colleague Lieve spoke about in her presentation and that I alluded to in that case scenario, UPD, which I also alluded to in that previous case scenario. So again, as part of that counseling flipbook in your conversations with trying to explain things to patients, some patients like visual information, some patients just like verbal, some patients like both, healthcare providers have found this helpful. And also when we look at what pregnant women want, there are lots of studies out there that have been done looking at what tools help patients in their decision making. And you see a consistency in what is reported in these studies, and that is, the ability to have time to talk about this. And I know when you're talking to patients in a pre-test counseling situation, there is not a lot of time. And more tests are being offered to patients that's just decreasing the amount of time, the amount of small time that we even already had. So patients, are noticing that, just like healthcare providers are noticing that, and they really would like things that allow them to reflect on things together at home, have tools that are available for downloading. They want a few days to think about things, something to take home to remember it, the information broken down in different ways. And studies have shown that women who have the time to ponder and think about these things actually show the highest knowledge scores, improving their informed consent decision-making process, but also truly being able to have informed choice. And the next few slides here, as I promised, are showing you what we call NIPT Insights. It is a pre-test counseling tool that was developed by 3 of our genetic counselors on our medical affairs team here at Illumina, in conjunction with other experts in the field and in partnering with patient advocacy groups and beta testing with healthcare providers in various countries and key opinion leaders. And it really is an aid to help expectant parents, and again, this is for the parents, to make informed decisions. And it speaks to what I showed you on the previous slide with what patients are really wanting. It is currently available in multiple countries and languages, including South Africa. The purpose, again, behind it is to overcome the barriers that we see with this informed consent process, not only from the healthcare provider's lack of time, but also to help patients to feel like they have enough time to digest all that information and truly make an informed choice. It launched in select countries in 2018, and as I mentioned, it is now available in South Africa. It is not branded. It is freely available on the Apple and Google stores. There is a pilot study that is currently ongoing looking at the impact of this, and those results are pending. And there are plans to continue to expand it into other geographies and languages. And these next few slides here are just snapshots for you, showing a breakdown of it. When you enter the app, you select the country where you are. And for South Africa, it's available in English. It'll ask you these various questions, telling you that it's going to give you more information about NIPT and the ability to compare it to other screening and testing options. And you have the ability to save any topics that you want to look at further or discuss with your healthcare provider. You have the option to do that. You see the sections here. It's a tiled approach broken down by topic. You can move backwards and forwards. It is self-paced. If you were to click on one of these tiles, for example, here, what is this test about? It's giving you basic information about chromosomes, the highlights. There is the option to read more if you want. There's references here for you. and then the ability to save it to your appointment notes if this is something that you want to discuss further with your healthcare provider, or even just go back for yourself to be able to look at later, the patient themselves. In that appointment notes section, there is the ability for the patient not only to save that information, but to write down any other notes that they may want to discuss with the healthcare provider. And in addition to information-based, there is also a personal values assessment. You know, again, talking about not just informed consent by having enough information to decide, but also making a decision that aligns with your values and your personal assessments. And there is that portion here to that app for the patients. There are other resources in there that are available. There's more information on NIPT, a glossary, references. And in this section on more on NIPT, there is speaking about the fact that some labs do screen beyond the common aneuploidies, and advising you to talk to your lab about those things and find out what is available. So that's a pre-test counseling tool that is available to patients. Again, it's publicly available. It is now available in South Africa. It is non-branded. This next tool here is more of a post-test counseling tool, and it's what we call a healthcare provider information sheet. And it is next genetics with every screen positive NIPT result does attach to it this information sheet that will contain information for the particular condition that the NIPT result was screen positive for. And it talks about, this is an example with trisomy 16. It talks about what is trisomy 16, the features, how common is this condition, and then importantly for those post-test conversations with patients, what testing do I need to talk about with my patient? And are there any particular special considerations I need to think about in that post-test counseling testing conversation, such as that case example that I showed you before, where because it was involving chromosome 15, you know, UPD testing would be indicated. That would be information that is there for you if additional type of testing is recommended based on what that NIPT is result is screen positive for. And again, in addition, Next Genetics also with any screen positive NIPT result does offer genetic counseling services to be able to talk to your patients for you, again, for screen positive results. So another tool and resource available to you. And then finally, those resources that I showed were more from a counseling perspective, both pre and post-test counseling. This next information here is just a website that's available for you. It is healthcare provider discontinuing education. It is a journal resource center that is sponsored by Illumina with Wiley Publications, and they publish many journals globally, including prenatal diagnosis. The information on it can be found at niptupdate.com. It is unbranded. There is a editor that is responsible for the managing of the site that is not an Illumina employee. It's actually a key opinion leader in the field who has a lot of experience with expanded NIPT. His name is Professor Joris Vermeesch from Belgium. And if you recall, that's one of the countries I mentioned that has a lot of experience with expanded NIPT. He posts research articles that are of interest. He has topics of the month. There are other tools and resources available on there for you. In addition to publications, things that you may find handy, including the patient counseling guide, but there are other resources there available as well. And then finally, just reminding you things to consider, as I know this is a lot of information to think about, just for NIPT in general, whether it's basic or expanded NIPT. Like any test, the risk assessment is limited to what it's looking for. So keeping in mind, is NIPT the appropriate test for my patient, which is information that you gain during that pre-test counseling piece. And then nothing is 100%. And so because of that, reminding you, regardless of what NIPT is being performed, follow-up testing, confirmatory testing with screen positive results by a CVS or an amniocentesis is recommended. If patients choose not to do anything further prenatally, then definitely postnatal testing. And then there may be special considerations for additional testing on the CVS and amnio or postnatal testing that may need to be done depending upon what the NIPT result was screen positive for. Collectively, when we think about testing beyond the common aneuploidies, these conditions, they're not rare when you look at them collectively, and they do have clinical significance. If you think back to those tables that I showed you about screen positive rates, they collectively have a higher screen positive rate than sex chromosome aneuploidies. and approaches that of what we see for the common aneuploidies that we're already screening for. And then again, appropriate counseling to ensure informed choice and informed consent. And there are tools available out there to help you and also your patients in be able to explain and digest this information. And with that, I thank you for your time, and I'm happy to take any questions.
Thank you, Christin. That was such a great overview of how to approach these sessions. And I think the resources you've mentioned are going to be a great benefit to all clinicians offering NIPT. We've had a few questions, if you're happy to answer them.
Absolutely.
So during a pre-test counselling session, how much information should be provided regarding the possible outcomes of the test?
You know, that's a great question, Kelly, and one as a counselor myself, I've grappled with over the years, not just with regards to NIPT, but just in general, when you're talking to patients about all the testing and screening options that are available for them. And keeping in mind, and I like to drive this point home, that what we're looking at with expanded NIPT, it's not, genome-wide testing is not new. It is something that we've been doing for decades in the form of karyotyping on amnio, karyotyping on CVS, as the resolution of karyotypes is increased, microarrays, and keeping in mind what are those conversations that you've had as healthcare providers with patients when you're offering those test options. Do you go over every single chromosome condition that can be identified on those? Or do you present a general overview of, okay, what this test is able to look for are looking at all chromosomes, extra missing whole copies, extra or missing pieces down to a certain amount. And sometimes I don't even know if I'd say that to a patient, but just letting them know extra missing whole copies or missing or extra pieces of chromosomes. And that can have impact on a pregnancy in the form of, there could be birth defects, there could be pregnancy management things that we need to think about, syndromes, and, letting them know that that's what we're looking at. And then those more detailed conversations of what the result actually means if something is found to be screen positive, that would help us to tailor that conversation in a post-test counseling type of situation, but really just giving them that overview similar to the conversations you'd have with a CVS or an amniocentesis. And the other important piece is not just that, but just reminding them of those risks and benefits and limitations is really important. The difference between a screening test and a diagnostic test, and reminding them that if something is found on their NIPT, you will be recommending additional testing to them. That there is a risk associated with those things, and that additional testing that would be recommended on that CVS or amnio really would depend upon what the result came back positive for, if it even did. Because as we all know, the majority of cases are fine, which as a counselor, I always like to remind people of, we always focus on what we're screening for, but reminding them that most pregnancies are fine, but this is the testing we can offer you, and framing it in the same framework that you would talk about how much information do you give them when you're talking about CVS and amnio, but reminding them that follow-up testing would be indicated if something is found.
Perfect, thank you. I think there's so much information available that sometimes it just feels a little overwhelming.
Yes.
Trying to decide what is the most important to share with the patient.
Absolutely.
So the next question is confirming an abnormal NIPT result, so a high-risk result, by CVS useful if we're still testing placental tissue?
No, that's a great question, and one I get a lot. It's a very fair question. And taking that step back from what Kelly just said, reminding you of the source of what we're testing, and how I used the analogy in the beginning of NIPT is kind of like a CVS blood test because of where the cell-free DNA from the pregnancy is coming from. And I spoke earlier about a key opinion leader named Francesca Gratti, G-R-A-T-I, and she has a really great publication out there that talks about this very question. Based on what my NIPT result is positive for, should I offer a patient a CVS or an amniocentesis? And it's not a one-size-fits-all approach, really broken down by what did the NIPT results show, and using that in conjunctions to what we know about that chromosome abnormality. And also if we are seeing anything on an ultrasound or something like that, and really helping that to guide your conversation. So it's not a simple, you should wait for an amniocentesis and not do a CVS, or only do CVS and not do amnio, really is it's going to be guided by what came back screen positive on the NIPT, and then what we know about that chromosome condition. And that, again, I'd like to remind healthcare providers where genetic counselors and other people with experience in this field are great resources. Those physician info sheets that I highlighted will contain that information, and then using NextBio as a resource, specifically Kelly, to help them in those conversations. And I know that for some, they would rather not wait. Some people would rather have information sooner rather than later, and that is something that needs to be taken into account. Also, the nuances of, if there are situations sometimes where a CVS and an amnio, may be something that needs to be considered for a patient, and there are practical considerations regarding that as well that need to be taken into account beyond a medical standpoint, and I appreciate that as well. So I hope that's helpful and helps to answer that question.
Yeah, it's really helpful, and I think that that article will be very useful to have a look at. I think this often comes up because we're providing results at such an early stage for some patients, because the testing can be done from 10 weeks. Having to then wait for an amnio is sometimes very tricky for some patients. So having a bit more guidance, I think, will be very useful.
Absolutely.
Okay, and then one more question. So if you have a high fetal fraction at an early gestational age, is that concerning? So if, for example, you have a patient that had a high-risk serum screen, then has a normal NIPT result, so a high-risk serum screen for trisomy 21, normal NIPT, but a very high fetal fraction, would you be concerned?
Not necessarily, no.
Okay.
So in the scenario that you're describing, so a high-risk, say, first trimester screen for Down syndrome?
Yes.
And the NIPT was screen negative?
Yeah, but with a high fetal fraction at quite an early gestational age.
Yeah, so, I think the one question that I would want people to look at is really beyond just the risk score on their first trimester screening result. And there is data coming out there, actually taking a look at those analyte levels. As we know, the first trimester combined test not only looks at ultrasound assessment by nuchal translucency and crown rump length, but also two markers in a pregnant woman's bloodstream, HCG and PAP-A. And there have been some publications out there showing that a significant skewing in those values, and what we've seen specifically is extremely low PAP-A levels, can be associated with pregnancy-related complications. And if you're limiting your risk assessment to just trisomy 21 and it's screen negative, if you're just limiting your NIPT to 21, 18, 13, it may be something to consider looking beyond those things for an expanded panel. You may be concerned about the function of the placenta in and of itself. If it really is drastically high for the fetal fraction estimate, and I say looking at that PAP-A level, because that can give us an indication if there's any risk for pregnancy-related complications contributing to an unusually high fetal fraction result. But the high fetal
really useful
result wouldn't make me think that the T21 result is wrong, for example, on the NIPT. It made me think about other things related to monitoring that pregnancy.
Okay, so almost in the same way that you need to be concerned about a low fetal fraction just to look at the pregnancy as a whole.
Yes. And then if they weren't looking at an expanded NIPT type of situation, thinking beyond just 21, 18, and 13, if that PAP-A is really low or there's something else there going on.
Perfect. Thank you so much, Christin. We don't have any other questions that have come in, so also bearing time in mind, I think we will end it there. And we just need to say thank you so much for your time and being with us very early, your time.
Oh, it's my
really
pleasure.
Appreciate it. And that was a really great talk.
Thank you. And I really appreciate the chance to speak with you all. And I wish you all a very wonderful evening, and stay safe during these times, please.
Thank you. You too.
Thank you.